ossicles and the middle ear, both preoperatively and in some other situations as well, because it's a pretty vast topic, imaging of the temporal bone. This particular presentations that you will see in this presentation belong to me. None of them have been downloaded from the internet or any form of social media. I thank the ORL Journal for allowing me to use the gross anatomy pictures that you would see during the presentation. We would have an accompanying gross anatomy picture so that it will help you identify these structures. However, I'd like to make one small point here, that for the rest of the structures, the exact correlation might not be available because obviously they are not from the same patient, right? So you might find some differences as far as the rest of the structures is concerned. So here I've tried maintaining the correlation mainly in respect to the ossicles. Now, as far as the action scans are concerned, my personal belief is to always read these scans superior to inferior rather than inferior to superior, because you see the cluttering of these structures and the sort of dirtiness that you see in the CT scan is more concentrated towards the inferior sections, and therefore if you're coming down to superior to inferior, you start gradually getting familiar with the structures, and hence identification of the more complicated structures in the mesotympanum becomes easy for you. So this is one of the uppermost scans wherein you don't see any ossicles. What you definitely see are the two limbs of the superior semicircular canal with faintly the intersubarcuate artery, or what is in radiological terms called the petromastoid canal, visible in between the two limbs. This is probably the antrum of the upper part of the attic area with the antral air cells all around, and you can jolly see the correlation on the anatomical picture. Now, as we move down, we start seeing the upper part of the intrudomedular joint. So that is the head of the malleus. That is the body of the incus, which will later start showing the short process of the incus pointing towards the actus. And you see the intrudomedular joint again correlated here. Not only that, right anterior to the head of the malleus, you see this bony septum, which we all know as the cork, right? And in fact, that is well correlated here on the gross specimen as well. And you do have a cell anterior to the cork. So in a way, the scan helps you in understanding the fact that beyond the cork there could be pathology. And if you take this cork as the end point of your dissection during surgery, you could land into trouble, leaving behind residual disease. Anyway, so you see the head of the malleus, the incus and the intrudomedular joint. As we move down further, the classical appearance, the eye stream cone appearance of the intrudomedular joint in the attic or the epitympanum area becomes very, very clear. So the anterior part of the eye stream cone appearance is formed by the head of the malleus, and the cone of the so-called eye stream cone appearance is formed by the body of the incus and the short process of the incus, again pointing towards the actus ad antrum, seen here as well. This is a more gross picture of the incus and the malleus with the intrudomedular joint, and how it would look if you look at it at the intrudomedular joint from the top, keeping the intrudomedular joint in your hand below you. We move further down. As we move further down, the attic area becomes a little larger. The intrudomedular joint becomes a little distorted, right? Again correlated here. And then you start seeing the external auditory canal and this fine piece of bone, which we pathologists know very well as the sputum or the lateral attic wall, one of the first areas to be involved in localized cholesteatoma. So you have the entire intrudomedular joint. Now from here onwards, I would like you to pay attention to, I'll just go back to the scan and look at that. What is that structure there? Anyone please? That's the tympanic segment of the facial nerve. Can you make that out? That's the tympanic segment of the facial nerve. So this is the tympanic segment of the facial nerve.
That's a labyrinthine segment of the facial nerve, and so this is your geniculate ganglion. Why is it important to identify? Because as you go lower down, you will find that this area is replaced by another structure, which if you look at it isolatedly, will give you the wrong notion that it is the tympanic segment of the facial nerve. So, right now, in this scan that we were earlier talking about, you can see the entire tympanic segment of the facial nerve. That's the entire tympanic segment of the facial nerve. Now that you have seen the entire tympanic segment of the facial nerve, you need to understand that as you go lower down, your facial nerve should not be there where it is visible now. Because from the tympanic segment, it would form the second genu and then the vertebral segment. So, this being the tympanic segment of the facial nerve in its almost in its entirety, and as we know, this is the lateral semicircular canal. You can see almost the entire thing of the lateral semicircular canal. We know that right inferior to the lateral semicircular canal, the facial nerve is going to take a downward turn and get converted into the transverse segment. So that is exactly what is happening in the next scan. Now, if you haven't paid attention to the previous scan, I'm just digressing here a little from the ossicles because this is extremely important. Now, if you haven't paid attention to the previous scans, you might well have mistaken this structure as the facial nerve tympanic segment, but that is not the case. If you follow the structure properly, both on the scan and on the gross segment, you see that the structure comes back, takes a turn at a bulbous structure, becomes thin and goes towards the valleys. So this is the tensor tympani muscle, as you can see here. This is the entire tensor tympani muscle going towards the eustachian tube, taking a turn, coming out of the bulbous structure, that is the cochleariform process, and getting converted into the tensor tympani tendon and therefore getting attached to the neck of the mandible. So this is extremely important. And so, where is the facial nerve now? Now the facial nerve has come here. That's the vertical segment of the facial nerve. So now the facial nerve has come here, very well correlated on the gross anatomy, which is this. This is the facial nerve. So this is the handle of the malleus, or maybe the junction of the neck and the handle of the malleus, however you choose to call it. And now, we covered the body of the incus. We covered the short process of the incus. So now what stays? We are at the long process of the incus. Correct? So on an axial scan, long process of the incus, because the scan is passing perpendicular to the long axis of the long process of the incus, it appears circular. So this is your long process of the incus, this is your handle of the malleus. We are still in the slightly upper part, and hence we are not seeing the tympanic membrane completely. But this is the area of the lateral wall of the attic or the scutum, or also known as the Prusac space. Now you can see that this is the facial nerve, and if this is where the tympanic annulus would be, so this is the area of the facial recess. Going down further, it makes it very, very clear to you now. This is one picture you need to put it in your mind as the best possible appearance of a large number of important structures on an axial scan. That's the handle of malleus. You can still see the cochleariform process. You can faintly see the tensor tympani tendon. Can you see it on the screen? There's the contrast all right there. Okay? So that's the tensor tympani tendon going towards the handle of the malleus. Right? That's the short process of the long process of the incus gradually getting converted into the lenticular process, turning, and not only that, we see the anterior crus, the posterior crus, and the head of the stapes. So this is the area of the incudo-stapedial joint, and this sign is called the two parallel lines sign in radiology terms. The anterior parallel line is the cochleariform process, the tensor tympani tendon, and the handle of the malleus. And the posterior parallel line is the long lenticular process of the incus and the stapedial superstructure. And we can see that the stapedial superstructure, at the base of the stapedial superstructure, obviously lies the foot plate of the stapes, which in turn lies on the vestibule. Not only that, the facial nerve is here. This is your facial nerve here, right? Right? It's housed within the pyramidal process. This is your tympanic annulus. So this part now becomes a facial recess, and this part becomes the sinus tympani. So that is why I said that this particular cut is absolutely mandatory when you ask for an HRCT, especially if you're doing posterior surgery and you wish to know what the depth of your sinus tympani is, whether it is possible for you to do a blind dissection, how deep does the soft tissue go inside, so on and so forth. So never ever leave a scan without searching for this particular segment. Same correlation maintained here, tympanic annulus, tympanic membrane with the handle of the malleus, the arch of the stapes, the head of the stapes, the lenticular process, the facial nerve within the facial canal, facial recess, and the sinus tympani. Now as we move down, the ossicles will start disappearing. We can very well see that we no longer see the stapes. The basal term of the cochlea becomes prominent because we will start approaching the promontory and the round window niche. The malleus becomes converted into the handle, and because sometimes the malleus handle can be at an angle, it will be medialized. Sometimes you will see the malleus handle as straight. Very faintly you see the inferior stapedial joint here. That is the area of the facial nerve, the facial recess, and the sinus tympani, again correlated on the gross segment. Finally, lower down, just a little part of the this is the tympanic membrane faintly visible here, correlated here, and the lower part of the malleus handle, the facial nerve, recess, sinus tympani, the promontory with a basal turn, and that is your round window niche. Now, why is this segment important? This particular section becomes important for surgeons performing the cochlear implant. You need to know how much of a window do you have between the tympanic annulus and the facial nerve, because that is where you are going to perform your posterior tympanotomy. And what is the kind of overhang that you have as far as the round window niche is concerned. Finally, everything disappears, no further ossicles visible, just the basal term of the cochlea and an empty mesoderm. Right? So before I move on to the coronal sections, I would once again like to reiterate that this is one section that you should have while you are sort of interpreting a CT temporal bone. And I'm not saying that the other segments are not important. In fact, I would not be, it would be, however much I reiterate, it would be much less that scans should not be read in isolation. They should be read in continuity, axial superior to inferior and coronal posterior to anterior. Don't just pick up an image and try finding your way out. There is a chance that you could make a mistake. So as you can see, it's the yellow area which indicates the facial recess and the red arrow which indicates the sinus tympani area. From here onwards, we move on to the coronal section. Again, for my protocol for reading the coronal sections is very simple. Go posterior to anterior again, because there is a paucity of structures posteriorly, and as you keep on moving anteriorly, it becomes more crowded and it's easier for you to correlate the structures. Now this is one of the posterior scan, and I wouldn't say this is the most posterior scan because you're not seeing the posterior canal here. That is what you would normally see on the more posterior scans, but as I mentioned, this presentation is more about the ossicles. So as the ossicles start getting visible on the coronal section, what do we see first? The first thing that we see is this small pinpoint, which is the short process of the incus, right? Because we're moving from posterior to anterior, so we should be expecting the short process of the incus, the body of the incus, the ingulomalleolar joint, the head of the malleus. The handle of the malleus can be a little dubious because, again, as far as the angulation of the malleus is concerned, it varies, and therefore you could maybe see the handle of malleus even a little earlier. Anyway, not only that, what you also see here is the oval window, the opening in the vestibule. Mind you, this is the oval window. Why? Because the round window would be much inferiorly located. So this is not to be mistaken as the round window. Right, and not only that, very faintly you can make out the suprastructure of the stapes Again, correlated here, this small dot that you see here is the incus short process. That's the superstructure of the stapes. That's the full plate and the opening into the vestibule. And this is the tympanic segment of the facial nerve. Right underneath the lateral semicircular canal. So right underneath, this is the tympanic segment of the facial nerve, right underneath the lateral semicircular canal. Okay, and this again in radiology terms is called the braid hanging from a branch, because the branch is supposed, the lateral semicircular canal is supposed to be the branch, and the tympanic segment is supposed to be the solitary braid hanging from that branch. We move a little more anterior, right? The point becomes a little wider. It still is the short process of the incus. The superior head becomes more prominent, as does the opening into the vestibule. Again, correlated here. Moreover, that's the lateral semicircular canal, and that is the anterior end of the superior semicircular canal. So this is the lateral semicircular canal, the anterior end of the superior semicircular canal, the head of the stapes, somewhere here. Somewhere here is the incus, and this is the tympanic segment of the facial nerve. We come more anterior and we start seeing the body of the incus. Again, because of the angulation, we see a break in between on the gross anatomy, not so much as on the on the coronal scan. So that's the body of the incus, and if you just follow it downwards, that's the long process of the incus, turning into the lenticular process and getting attached to the head of the stapes with the anterior crust here and the posterior crust there. So the same thing happens on the coronal scan. That's the body of the incus. Follow it downwards, the long process, it turns, lenticular process, head of the stapes into the stapedial joint. And this, my friends, is the tympanic segment of the facial nerve here, which you can see here on the gross section. So this is the tympanic segment of the facial nerve. And now we come to another more important structure, which is better visible on a coronal scan rather than on an axial scan, and which is this one. And that is the lateral attic wall or the sputum, again, more liable to erosion in localized cases of cholesteatoma. So when you are dealing with a localized case of cholesteatoma, you need to see whether there is acute angulation between the external auditory canal wall and the lateral wall of the attic, whether there is any erosion or not. A little more anteriorly, now this is the entire body of the incus. This is the entire body of the incus, but mind you, this is not the long process of the incus anymore, because the moment you have the incudostapedial joint, the incus is over as far as the long process is concerned. It's so flimsy, right? So as you can see out from the cross section, this is the body of the incus, and this is the body of the incus, because you can differentiate it from the head of the malleus the moment you see the next few sections. But this, friends, is the handle of the malleus with the lateral process of the malleus embedded into the tympanic membrane. So do not mistake this shadow here as the lateral long process of the incus. So this is the body of the incus, but this is the handle of the malleus with probably the lateral process of the malleus embedded into the tympanic membrane. Now look, this is what the head of malleus looks like. Compare it with this. Okay? So this is what the head of the malleus looks like, and this is the body of the incus. So this is the inferior joint. So now again compare this. This is a bilobed appearance. So this is not just the incus, it's not just the malleus, it's the inferior joint. So the bilobed appearance that you get on a coronal section of the bones in the attic is the inferior joint. You can see a small dimple or a notch here. You can see a small dimple or a notch here, which corresponds to this dimple or a notch which is seen at the joint interface, right? So this is the body of the incus, the head of the malleus. Now you can see the handle of the malleus and the tympanic membrane with the lateral process of the malleus. Not only that, you see the cochlea-form process here and the tensor tympani tendon coming out and attaching itself to the neck of the malleus. Not only that, you actually see the os flaccida here. So this is the area of the Cusack's space. So if you have a good radiologist, if you have a good CT machine, believe me, it's possible to do wonders as far as HRCT temporal bone is concerned. And mind you, the picture that I'm using right now they're almost 14 years old. I'm sure HRCT temporal has progressed by leaps and bounds. Anyway, so this is where your cochlearly formed process with the tensor tympani muscle is. So in that case, this is your tympanic segment of the facial nerve. This is the labyrinthine segment of the facial nerve, and these are the basal terms of the cochlea. Why am I paying attention to this? Is because of what I'm going to show you in the next segment. Similarly, so head of malleus, body of incus, inguinal joint, lateral process of malleus, pars flexilla, tensor tympani, and we have the facial nerve over here. Right. We move more anteriorly, and now we see the incus here because this is a gross section. So it's more three-dimensionally oriented, whereas a CT scan and HRCT is a sub 1 millimeter cut. So this is isolatedly the head of the malleus. Whereas over here you can still see the head of the malleus with a part of the body of the incus behind. Anyway, this is the head of the malleus, again neck of malleus, lateral process, and the tympanic membrane over here and over here. You see the basal turn of the cochlea and the two segments of the facial nerve, that is the tympanic segment and the genital and the labyrinthine segment. And this in radiological terms is called the cobra head appearance. The head of a cobra with the two eyes on top, and you are having a head on view of the cobra. The cobra is in front of you. So the coils of the cochlea is the head of the cobra, and the two segments of the facial nerve are the two eyes of the cobra, right? So this is the cobra head appearance of the cochlear facial nerve complex on the coronal section of HRCT temporal bone. As we move more anterior, the structures become lesser and lesser as far as the ossicles are concerned. The turns of the cochlea are visible, and now what we see are the two segments of the facial nerve, the tympanic and the labyrinthine segment, fusing together to form the geniculate ganglion. So this is the geniculate ganglion. Mind you, this is not the facial nerve, this is not one part of the facial nerve and the other part of the facial nerve. This is the two parts of the facial nerve combined together to form the geniculate ganglion, whereas this is the tensor tympani muscle and the last remnant of the head of the malleus with the rest of the tympanic membrane visible. Finally, everything disappears, just a far haze as far as the turns of the cochlea are concerned, the geniculate ganglion, and this is the vertebral part of the internal carotid artery. Nothing more to see here. As I said, as you move more anteriorly, the number of structures become lesser and lesser. Now, I think you would agree to me, if we had gone anterior to posterior, it would have been a little difficult for us to identify the ossicles, more so when it came to the handle of the malleus, the long process of the incus, and that is why my suggestion, my personal suggestion is always to come posterior to anterior. Right. Now, just reiterating some final points before we go into the last part of the talk, and that is the pathologies. And that is, as I mentioned, this is the body of the incus, and this is the head of the malleus. Why are they being shown side by side? Look at the long axis, the orientation of the long axis of the two structures, so that you don't make a mistake. The body of the incus, the long axis, is obliquely oriented, whereas as far as the head of the malleus is concerned, its long axis is more vertical. So that's one important point to understand, or rather to help you differentiate between the body of the incus and the head of the malleus. The other part is this bilobe structure. Never make the mistake of considering this either as the body of the incus or solely or as the head of the malleus. This is the inguinal joint, with the posterior part being the body of the incus and the anterior part being the head of the malleus, and the dimple indicating the junction of the interface. Finally, on sagittal sections, not many people do a sagittal section, and honestly it's not much of a help, but this is the classical molar tooth appearance of the inguinal joint on a sagittal section. That's a sagittal section of the left ear. That's the head of the malleus at the handle. Body of the incus, short process of the incus, long process. So it looks like a molar tooth. So that's a classical molar tooth appearance of the sagittal section. It is helpful. You see, if you do a sagittal section and you get this appearance, at least when you go in for a surgery, you know that out of three, two of your ossicles are already present. It's more of a positive value in its presence rather than its negative value in its absence, which can help you not only plan your surgery but also counsel your patient. Now, just a few slides as far as identifying certain pathologies are concerned. This is a typical case of chronic otitis media. Why I say chronic otitis media is because of the soft tissue present all around, which has led to a disarticulation between the head of the malleus and the body of the incus. So from our previous knowledge of what we heard in the last 15-20 minutes or so, we know that this is the typical ice cream cone appearance, but we can jolly well see that the ice cream cone appearance has got disarticulated because of the pathology surrounding it. Right? That's a coronal section. This is what a localized cholesteatoma in the crusaxial space, eroding the outer attic wall would look like, as I mentioned. Look how the blunting that we had seen on the coronal sections is lost. And not only that, the ossicles are surrounded by the pathology, and there seems to be some erosion of the ossicles secondary to the pathology. Now, you can see the tympanic membrane here. If you see the tympanic membrane here, it means you're quite far anterior, right? So you should be expecting at least the head of the malleus here. But you can very well see that there is a pathology, and you can just see a faint bit of some ossicle line here. So your head of malleus, or not only that, we are seeing the typical cobra head appearance. Are we seeing the cobra head appearance here? Yes, friends? Yes? So the turns of the cochlea, the labyrinthine segment, and the tympanic segment. So this is the cobra head appearance. So the cobra head appearance would not be associated with the incus. So what is the ossicle we should have expected here? That would have been the malleus, and it is eroded by the pathology. Not only that, look, this is the tympanic segment of the facial nerve. Do you see any bone here? No. So probably you deal with the dehiscent facial nerve secondary to this pathology. Now this is a traumatic disarticulation. The typical ice cream cone appearance is lost. That's the head of the malleus. That's the body and the short process of the incus. There is no pathology around. Not only that, there is a fracture line here. So if you look at the fracture line, you can understand this is a traumatic dislocation rather than an inflammatory dislocation secondary to a chronic otitis media, and that is the area of the dislocation. Again, gross involvement, the tegmen is eroded. Not only is the tegmen eroded, this is the head of the malleus, right? Again, the cobra head appearance, correct? The cobra head appearance, the head of the malleus, in fact, you can see the angle of the malleus, and the pathology has come out and has eroded the lateral attic wall to a gross extent. Same kind of an appearance, ossicles eroded, tegmen eroded, pathology, typical cobra head appearance. Now, the last part. We normally do these scans preoperatively, either for a primary patient when we are suspecting some complication, or we do the scan in a revision case. When you are doing the revision case, especially if the case is, if the revision is for a modified radical hysterectomy or otherwise, you need to know whether the cavity created is good or not. And you can get evidence from the CT scan to ascertain whether the cavity created by either you or the previous surgeon is good or not. Now this is a typical example of a good cavity. Look, this is where the facial nerve is. The facial ridge has been lowered down to a large extent. There are no unnecessary undulations in the entire cavity. I mean, you do not have a deep groove here. You'll appreciate that in the next few slides. There's no deep groove here, and the soft tissue, the metaplasty is pretty wide. So a wide cavity with wide comproplasty allowing good aeration. So this is an evidence of a good cavity on a CT scan. Same thing. This is a facial nerve. Now look at the sinus tympani. Probably you would have been happier if you would have flattened it out more, but can we? No. Unless and until we are doing a facial nerve decompression, or unless and until we intentionally want to do a facial nerve. So this is your sinus tympani, and this is good disease clearance because postoperatively there is no postoperative appearance, there is no dizziness here, no pathology here. That's your facial nerve, and look at the metaplasty. Same thing. Look at the wide metaplasty. This is much above, much higher above. So the cortical bone has been removed remarkably well to give us a wide opening into the cavity. But this is a typical example of a poor cavity. Look at the left side of the scan. Look where the facial nerve is. And see how much of a bone, how much of a facial ridge has been left behind, dividing the entire cavity into two compartments. This cavity is going to be till kingdom comes, unless and until you revise this surgery and bring this facial ridge down. So this is a typical example of a poor cavity. Not only that, it gives you, if you are going in as a secondary surgeon, it gives you the confidence that, okay, fine, there's a decent amount of bone on top of the facial nerve that I can remove before I should expect the facial nerve. And if we do remove, not only that, whether I can give a good cavity or not, if I do remove this bone right up to this level, this line becomes more straight. So, post-operative evaluation of CT for resurgery is a very, very important and effective tool. Same case, look at the amount of bone that has been left behind. Look at the amount of bone that has been left behind, how a mastoid sum effect has been created here. Right? Same thing, poor cavity on a coronal section. Now I just spoke to you about doing a wide cortical mastoidectomy, removing the cortical bone. Look at the amount of the cortical bone that has been left out here. This bone should not be existing. This bone should be as thin as this is, and it should be ending here. So this entire triangular piece of bone is what is giving rise to a problem. Again, the mastoid reservoir or the sump effect. This also is a poor cavity. What have we been told? That if possible, make sure that the floor of the mesotympanum or the hypotympanum is in continuation with the floor of the external auditory canal when you do a canal going down. But look at the hypotympanum here and look where the floor is, and there is no important structure here. So if I were doing this surgery, I would flatten this out more. Again, this is giving rise to that funnel effect, which is the root cause of most of the issues as far as a nasal cavity post-MRM is concerned. So that's about it as far as it's a very, very concise outlook for HRCT, because being an ossiculoplasty workshop, I wanted to concentrate more on the ossicles and their relationship with the surrounding structures. HRCT, I believe, is an important tool, and I also believe that every otologist should be capable of reading the scans themselves rather than depending upon their radiologist. Thank you very much.